Hey guys. Whoa. All right. We are live on YouTube. This is wonderful. First live. All right. I wrote a bunch of questions. I got a bunch of questions. We'll see how this goes. Okay, so this is the first time I'm doing this. Do you see I have my book and my brain back here? I also have my cranial drill. That's a fun toy. All right, so I have gotten quite a few questions just through Instagram and online, and I thought, and through all the comments on all the videos. So I thought, why don't I just start doing Q&As and people can let me know, specific questions. I can answer them in real time. So I took some of the older ones that I've gotten while people are hopping on, and if anyone has questions, I can answer those next. But and you may hear my dog, Tosh, he's here. Did a little ear flappy. So first question that I want to answer that I was given on Instagram, I believe, is, hold on, let me just make sure. Can everybody hear me okay? Okay. Is nursing a sustainable career? So a lot of you might be in school, getting ready to do that first year, or in the first few years of your experience as a nurse. And a lot of people will get here like, okay, you're going to want to leave it after a little while, and it's not sustainable. And am I going to be able to do this in 20 years? And I have a lot of feelings about whether or not nursing is a sustainable career. And I think that let me scooch you up so I'm not too far from the mic. I think for bedside nursing to be a sustainable career, you have to be very intentional and purposeful with a few specific things. Number one, your boundaries, which I think is healthy and helpful for anyone, but in particular with bedside nursing. It is very physically difficult, and especially if you're working night shift, and also with units frequently working short, people are often asked over and over again, can you come in? Can you come in? Can you pick up extra? Can you switch shifts? So I think that for nursing to be sustainable, you have to have kind of this internal system in place where you don't feel guilty when you tell them no, and you don't always pick up, and you don't stretch yourself too thin. And as you put your time in a unit and you decide this is what I like and where I want to be, that you're intentional with creating your boundaries, creating, hold on, I don't know if I'm loud enough. Am I loud enough? I just want to make sure you all can hear me good. Okay. If someone wants to comment and tell me if it's loud enough, that'd be great. I feel like it's probably not. So be intentional about your boundaries, be intentional about like, okay, I did my full week of work this week, and I don't feel bad about saying no, that I can't come in, or switching shifts with this person who never switches shifts with anyone else. Like being able to have those conversations and decide that thank you very much, Frankie, that it sounds good. Being able to have those, okay, I don't feel bad that I'm saying no, I can't come in, or that I'm not going to move my entire schedule around to accommodate somebody else. You also, at the same time, want to avoid complacency and getting bored. Because when you get really good at a specialty, you can kind of get to a point where you're like, I'm not learning quite as much, I'm getting complacent, and I'm not as challenged. So if you can do things that, maybe you go for your certification, maybe you sit on a committee, or maybe you decide, hey, I really like working with these doctors and this thing, I want to do this committee or something like that. But then there's also other ways you can get very creative with nursing, making it sustainable at the bedside. I know a lot of people who will do part-time nursing at the bedside and then do something else on the side. And between those two incomes, they have a full-time income. They're not doing 3 12s a week. Hello, Melissa. They're not doing 3 12s a week, which is, that it can be a lot. And especially if you're someone who maybe you started in the profession before you had kids. Oh, good. Thanks, Melissa. But maybe you started before you had kids. Maybe you have kids now and you're like, hey, I miss bedtime and wake up those days. And I want to be home more with my kids. And you decide, okay, maybe I am going to do part-time at the bedside and then some other part-time job, and you can even do part-time as nursing or PRN somewhere else, where maybe you do volunteer, or not volunteer, but you work at like a clinic in town and do like 2 days a week of something else with less hours. Nursing has so many opportunities to kind of build your ideal situation, but the ownership is on yourself to create that environment for yourself. I think that if you're someone who thinks, okay, I'm going to go to nursing school, I'm going to get a job in this really great ICU, and I'm going to work 312s for 30 years, and I'm going to constantly pick up, I'm going to constantly overwork myself, and think that that's going to like be sustainable. It's not. You have to know when to say no, you have to know when to say yes, and you have to know when you need to maybe be creative with how you structure your entire professional setup. I know quite a few people who do that PRN at 2 different places, or part-time at a hospital and part-time in a clinic or in a psych situation that's outpatient. There's just so many different things that you can do with that nursing degree. And it does not have to be that you're a full-time employee for one hospital for decades. Okay. Another question I've gotten are, okay, I've been a nurse and I don't know, for a year or two, what do I do next? I want to go to grad school, but what are my options? Because the grad school option in nursing is confusing. I've tried to write blog posts about these, and it is difficult to explain it all, right? Because there's multiple ways that you can get into or do grad school. And I used to think the only one was NP. Like, I'm either going to be a nurse practitioner or I'm going to have a bachelor's the rest of my life. But that's actually not it. So in terms of pursuing more education, there's a lot of different options, and it really depends on what you want to do. And my recommendation for people who are like, well, what do I go to grad school for? I want to change that question to, what do I want my ideal everyday to look like? Do I want to go into a hospital and see 20 patients and be part of their provider team? Do I want to work in a clinic and do I want to work in a clinic and do that? Or do I want to teach nursing students? Or do I want to teach patients? Do I want to, what do you want your day to look like? Okay. Because I've seen people go into NP school who say, I don't want to actually do shift work, but I want to work in a hospital. Like, if you're an NP and you want to work acute care, you're going to work holidays. You're going to maybe have to work nights, depending upon the service line it is. So find out what you would like your ideal days to look like in your professional career and work backwards from that. So there's kind of, when you go straight from, let's say you're at bedside, you're like, I want to do something else. I want to go further. So, and we'll say you don't want to stay at the bedside. You want to get a degree, another one. I used to think, again, NP was the only thing, but there's multiple options here. You can go the provider NP route, but you can also go the educator route. You can also go the leadership route. Okay. So when you become, let's say you were to become an NP, you don't work for that nursing unit. You work for a service line for doctors or the medical side of things. So you're no longer part of that hierarchy of being on the nursing unit. You work with the providers in a different capacity. Now, when we look at the bedside nurses, let's say you have a team of 30 nurses on a med-surg unit, and they have a nurse manager who is responsible for those 30 nurses and 10 CNAs. So if you wanted to get into leadership and you got you got an MSN, or I also know some nurse managers that also have an MBA, a Master's in Business Associate or Administration, because when you get up to leadership in the corporation of a hospital, hospitals are businesses, And when you are in leadership positions, it is very helpful to have a business degree, which some people love and some people hate, the fact that hospitals are businesses. So when you get into those leadership positions in hospital corporations, you have to have your mind around the business of it. How much does it cost to hire a new grad? How much does it cost to hire an experienced nurse? How much can I afford to buy this new vein finder for our unit? Can I afford to buy a bladder scanner? Probably not. You probably have to share it with other units, and it's really annoying to get it, but cost benefit thing, right? And when you get into leadership, you have to do things like it's not just business stuff, it's also managing personalities and ensuring that the team can work together, that they have the education they need, that they have the competencies they need, that they're mentally okay and doing okay with everything. The nurse manager job is definitely a challenge, but if you are someone who's like, one day I want to be CNO, Chief Nursing Officer, I want to be at the top of the ladder at my hospital, you can get a master's, absolutely, in nursing, but you do not have to get an NP. The NP, so it's like there's a master's of science in nursing. You can get this certification on top of your master's, which is an NP, okay? So let's say you got your NP and you decided, I don't want to take care of patients. You still have a master's of science in nursing. You don't have to work as an NP. You have your master's, if that makes sense. I got my master's in education because I decided I don't want to prescribe. I don't want to have to go in and see a list of patients. I really loved working side by side with nurses and educating nurses. So I got a master's in nursing education. So, and then there's also terminal degrees. So a terminal degree is the highest you can go, hence the name terminal. You can get a doctorate in nursing practice, a DNP, very popular these days. There's also the PhD option. I've done MBA in health management. Could I be able to directly apply for a job from Pakistan? Okay, let me read this question. Sorry, guys, and then I'll explain those two. I have done an MBA in health management. Could I be able to directly apply for a job from Pakistan? It depends on what your level of experience is with nurses and nursing, care, because while you might have health management, if you're applying for a nurse manager position, they may or may not want you to have some nursing experience or a nursing degree. So it would depend on the position you're applying for specifically. But if you're if you have an MBA in health management, that would be, very desirable in a hospital setting. So just because you couldn't be a nurse manager if you don't have a degree in nursing, doesn't mean that you can't find a position somewhere in the hospital with that awesome education. So PhD, DNP. PhD, I believe it's about 7 years. It is highly research-based. You can go straight from BSN to PhD. You're going to be doing research. The PhD option is for creating the research and studying various things and publishing things. Very different than DNP. You may work at a hospital as maybe a nurse scientist. Not a ton of those positions at the hospital, but or you might work for a nursing or college, university. You could be teaching from that perspective while doing research. DNP role is different. DNP role applies the research to clinical practice that the PhD creates, okay? So the PhD role is not seeing patients, is not prescribing, is not an NP, unless they got their NP before they did their PhD, but they're not working in that nurse practitioner role at all. It is a completely different thing. They're in academia. But then the DNP, now a lot of DNP, you can have a DNP because it is clinical, like that education pathway. You can get your DNP and NP at the same time. And actually the whole education kind of trend is switching to wanting nurse practitioners to have their doctorate. A lot of hospitals, especially larger acute care renowned facilities will want their nurse practitioners to have their doctorates. But that DNP, if they have their NP at the same time, they can work in a hospital, and they also can be leaders. There's a lot that you could, well, a lot you can do with both degrees. Technically, the PhD probably has a little bit more prestige behind it, but this is kind of a social construct, right? We kind of make that stuff up. But it is harder. It's longer, more hours. That kind of, it's different than that DNP, but those are those two other options. Now, when we're talking about those, though, we're talking, it takes, years to get there. Definitely a big financial and time commitment to those roles. So if you are thinking about doing something like that, I certainly wouldn't just, I would want anyone applying for those programs to know exactly what they're getting into because of how long it is, how expensive it is. And I would hate for someone to go through all of that, go into debt, and spend all that time for their day-to-day working at a college making research isn't what they really want to do, or seeing patients or teach or whatever it is. Want to make sure that whatever you do, whatever path you pursue, you're doing so with intention and really knowing what you're getting yourself into. All right. Feel free to submit any questions. Otherwise, I'm just going to keep going through the ones that I got beforehand. Okay. What to do when your nursing anxiety is too much to handle? I have certainly gotten that question quite a bit. I've also had to work through my own anxiety at the bedside quite a bit. And one thing I've certainly learned as nurses, have great poker faces. There are people who suffer with anxiety who you have absolutely no idea. So a few things. Now, there's kind of two aspects to answering this question. One is what are the things I can be doing every day to lower my anxiety threshold? And what can I do at the bedside when I am freaking out, right? I think there's those two. So we're going to talk about both of those. So things that you can do to lower your anxiety threshold, they're not anything too crazy. Making sure you're getting adequate sleep. And I'm talking like 8 hours, not 6 hours, 8 hours of sleep. Making sure that you're getting your body up and moving around during the day. I know it's very difficult to do that on your days off when you're physically exhausted. Yoga is something, and Tai Chi, those kinds of exercises that are difficult, but like very intentional and slow, and you really have to focus on them. That movement, that focus literally changes your brain. Neuroplasticity, when we do things like that, there is a body of evidence that shows that these activities literally lower your anxiety threshold. So if you can imagine, you work maybe Sunday, Monday, Tuesday, and those entire days off, you're doing very stressful things. You're around people who stress you out. You're worried about blank, blank, blank. You're not sleeping. You're taking Ambien to sleep and drinking coffee to stay awake. Those kinds of things all ramp you up, so that when you're at work, it's not like you can just turn that stuff off. So doing what you can in your time off to lower your anxiety threshold will be a advantageous thing to do when you're actually at the bedside. Another thing, and people hate this, a lot of people do, but meditation is a big one. And I'm not talking for an hour. I'm talking if you can do it for 2 or 3 minutes. Like, go on YouTube and find 3-minute meditation and do that. And 3 minutes, if you've never done it before, is a long time to try to think about nothing. But the more that you can do that, the lower your anxiety threshold is going to be. I meditate regularly, and it's not for an hour by any means. Like, I've been doing it for a while, and I'm like working myself up to 10 minutes, right? It's very difficult to sit there and let thoughts go by. But it's wonderful for your anxiety. So that's a great one. If you're someone who is like super stressed out constantly, and it's very difficult to get your mind around life and disconnect the dots. Highly recommend actually seeing through your hospital if you can do counseling. Hospitals tend to contract out with counseling agencies so that you can have private free counseling. I did that through my hospital. It was wonderful. I got a ton of free counseling and it helped a lot. And this counselor gave me lots of great tools to deal with my anxiety, because it's not just like they tell you something and then, oh, you're fixed. You have to kind of show up and do the work for yourself and be committed to saying, hey, I'm going to work on lowering my anxiety and being present and not just thinking it's going to go away all of a sudden one day. So highly recommend doing that. Completely anonymous, wonderful resource. I've not heard of a hospital who does not offer this. And to be honest, like counseling can be very expensive. And a lot of times the hospitals will contract with counseling agencies that are experienced in counseling healthcare providers. Because a lot of us also get anxiety from, we have an intense job where we work with really intimidating people and intimidating situations. But then you throw into the fact that we watch people die. People's lives are literally in our hands. And that can be really scary, especially if you missed something you didn't, you're so like upset that you missed, or you had a really tragic, serious patient death that really you're having a really hard time getting out of your brain. Like, they have those resources, but again, we have to take the ownership to go seek them out. So I've had a good experience with that. So I've heard other people have too, but you also could, there's a lot of online counseling options as well if you don't want to go in somewhere or you don't want to go through your own hospital. But then there's also things you can do in the moment when your anxiety is going crazy, which when I'm chatting with new grads, that seems to be the biggest thing is I can't control my anxiety in this moment. And I need the patients to like trust me and know that I know what I'm doing. Okay, get it, totally. So there's something called grounding techniques. I don't know if anyone's ever heard of that, but you can do a Google search for that. There's lots of great little things that you can do. So basically it's, oh yeah, Frankie, I will do that question next. So grounding techniques, basically, if you were trying to get your brain to focus on something else so it can stop freaking out about this, whatever anxious thought you have. And it's really important to remember that we are not our thoughts. We are separate from our thoughts. The person that you are, the individual that you are, we all have thoughts, we have emotions, but we are not those things. Thoughts can fly by, kind of like thoughts are kind of like birds. They can fly around by your head, but you don't have to let them make a nest in your hair, kind of a thing. So grounding techniques are separating from those thoughts. So there's one called the 5-4-3-2-1, where you focus intently on 5 things you can see. Like if I was doing it right now, I would focus on my microphone right here, like the details of my mic, or the details of the keyboard, or, I would focus intently on those things. 4 things I can feel. Can I, if I'm holding a pen, feeling my pen in my hand, something I can hear, clicking the pen or hearing a beep or whatever it might be, something you can smell. So essentially using your 5 senses to really pay attention to those things and thinking just about that thing. Another one is this great quick breath work thing. So if you're truly in the middle of like oh my gosh, I'm really freaking out here, go into the bathroom, close the door, take a second and put your hand on your belly, take a deep breath in, hold it for about 4 seconds, and then let it out over about 8 seconds. And try to do that for like 3 minutes. Okay. Deep breath in over 4 seconds, hold it 4 seconds, out, and do belly breaths. We have our vagus nerve, our 10th cranial nerve. It's the biggest nerve that we have. It goes from our brain. Part of it terminates in our heart, but the rest of it terminates in our like kind of gastrointestinal area. And if you can activate that nerve, it will slow your heart rate down and chill you out. So if you can take a few minutes, and you don't have to actually do the numbers and counting, but try to hold it, and that breathing in, holding it, and letting it out, really focus on a long exhale and doing belly breaths. And that will naturally lower your heart rate. And, and while you're doing that, just focusing on breathing in and breathing out. And those are the only thoughts you want going through your brain. Okay. So those are some little tips. I think I have a blog post called something for anxious nurses that goes over that, I think. All right, Frankie, can you share some thoughts on accelerated bachelor programs? Do they adequately prepare you? So I personally have not gone through a program like that. I went through a traditional bachelor's back in 2007 to 2010-ish, because I did my prereqs at a community college the year before. But accelerated programs, I have met quite a few people who have done them. And the nurses who I have personally worked with who have done accelerated programs, I felt like they prepared people on the same level. Like it was like people who were coming out of an accelerated program performed about the same as people coming out of a traditional bachelor's. That is probably because they are very rigorous and they have they're not easy to get into. So they only want people who are going to take it seriously to get through. Now, I say that without considering the whole COVID pandemic thing. With COVID, you probably didn't get the in-person clinical stuff that you really need. And when you're in an accelerated program, time is of the essence, and every clinic, not that every clinical doesn't count in a different setting, but every moment in clinical counts. So if you're in an 18-month program and for 16 of those months it's been COVID, that might be a different situation. But in normal life, where you do get every piece of your clinical and none of it's changed due to like a pandemic, I do think that they adequately prepare you. They are incredibly rigorous. You have to have a lot of just support. They're expensive. But I think they're very helpful especially for those people who have you have another bachelor's degree, demonstrate that you can get through collegiate coursework and complete that. So I think that they're a good thing for the profession personally. I know some people don't love that. But I definitely think that they're appropriate. And if you can get through them, great. I've seen some phenomenal nurses complete accelerated programs. And I do think that they do have their place in the nursing education realm. It's a good question. Thank you, Frankie. If anyone else has one, just go ahead and slide it in the chat. I can get back to my other list okay. Have I worked with any undergraduate nurses in your practice? If so, what makes a good undergraduate nurse? So does that mean like a nursing student? Hold on, Janelle, a little more info. Because at the bedside, everybody pretty much was undergraduate. There were a few people who had masters, but most people had bachelors. But do you mean like, student nurse and pay position? Okay, got it. Because I did that. I'm dating myself here. I did an internship, 2007 or so. I loved working. And then when I was at the bedside, I did work with students who were doing like a practicum. And I really enjoyed that because they were really interested in learning, and it wasn't like there was 10 other students there and it was, they had to be there by themselves, and it was me one-on-one with this student. Similar to a CNA in the United States. So you don't have the scope of a nurse or a student, but you're still a student. Get it. I have worked with people in that capacity, and I've enjoyed it. Now, honestly, a lot of times the students who are in like a paid internship are motivated. Not everyone seeks out a paid internship. And at a lot of hospitals that do have them, they're fairly competitive. So the people that are in those positions are often awesome. And I typically ran into that, where the people that had those positions really cared, and really wanted to learn more. And they just wanted, to get the most out of it. And when I was in that position, I felt like that too. Like I I got to see so many things that I didn't get to see in my normal clinical. And I got so much more one-on-one attention from the nurse because it's very different when you have like this situation versus there's 8 students from the same clinical group and they all are kind of flocking together and you have 3 of them with you. And it's very overwhelming as the bedside nurse to have to try to teach 3 different people, take care of your entire patient load and take care of yourself. So when I had that one-on-one student, and they were able to do things like learning how to do like those CNA type tasks, it was great. I really liked it because I knew, okay, so, and I think other nurses share this sentiment. When you have students, you know that, and students who are motivated and care, you have the space to share and educate them. And they are very motivated as opposed to some other students who just they don't care that much. They're just doing this to check off a box. And, okay, that's a great question. How to optimize that experience. So here's a big tip that I have. That's not your common tip, but one thing, if you are with someone who is a brand new nurse, please be aware of that. I have had, when I was a brand new nurse and I had students thrown with me, I was very overwhelmed. I barely knew what I was doing. And they were asking me lots of questions. They were good questions and questions you should ask. Absolutely. But I barely understood what was going on. I think I was out of orientation like 3 months and all of a sudden I have students with me and I'm barely getting through my shift. I still don't understand totally what's going on. Okay, I see that my patient's on D5 with 20 of K at 70 an hour, but I don't know why. I just know they're on it. And I don't know why they're on dexamethasone. And I don't know. I just know that they're on it. And I'm getting all these very good questions. And they're coming at me really quick, and I barely understand what's going on. So be aware of kind of the nurse that you're with. If they've been there for less than 6 months, they're probably still in like shock mode and trying to get through their day. And if they're quiet and reserved or maybe seem a little short with you about things, don't take it personally. They may be in survival mode. So I think having an awareness around that is really, really helpful because I have a other side of it when I've had students in clinical before, and it often can be people's first real experience at the bedside. I have seen people really lack social awareness where something crazy is going on. Like actually, here's a story. I had a situation where I had a patient who had issues with drugs and things. They were getting discharged and they were not getting the things that they wanted to be discharged with, right? Patient literally throwing things. I had to loudly call for security. I was very pregnant. It was a very serious situation. And another family member of this person is sobbing right next to me. And a student comes up to me and says, "Oh my gosh, I forgot to ask him about his bowel movement. I need to chart that for my assessment for our school." And I was like, that is what lacking social awareness looks like. That she was a very kind person, but seeing this situation in front of her, like what was the most important thing to her was getting her assignment done. I get it, right? Nursing school is intimidating and a lot, but like seeing, hey, there's a very serious situation going on. Maybe I should wait. Like I'm literally screaming for security, dealing with a crying patient's family member. Like let's hang on. You're not going to go ask him about his bowels right now. Like having social awareness is really, really important and I think that gets lost. So pay attention to my other tip. I'll get to Abby's question in just a second. And my other tip is so asking questions is really important. But when it starts going down, when things getting serious, we got to call this doctor, we got to do this, hey, do this. Don't ask questions then. Just do what they tell you to do. Observe, save your questions unless you genuinely don't know how to do something they're telling you to do. But why are they doing this? Why? Blah, blah, blah. Like, yes, I get you got those questions. But it's very difficult to quickly think critically through a situation that you are in charge of dealing with as the nurse and also simultaneously explain that to somebody else. So that's another way that you can have good social awareness. Last tip for Janelle when you have interesting situations, you hear about a med, mannitol. I've never given mannitol before, 3% saline or whatever it is. Go home and look it up. Like that's when you can see a patient situation and then connect it like that. Okay, I'll never forget. I had to give mannitol to this guy and I don't remember what it is. And I had to do these specific things. Go up and look it up that night if you don't have time. And that's how you really cement some learning in, when you can connect clinical concepts to a very specific situation. So that's my encouragement there. So have social awareness, I guess, is my thing. Oh, and don't be lazy. That's what people hate. If someone asks you to do something, or don't just sit on your phone at the nurse's station waiting to be told what to do, look for things to do. If you learn that there's, oh, hey, I can restock this, I can redo that, or what, or put this back, or clean this up, or clean these machines off. If nothing's going on, do that. It's very frustrating to be with people who will just sit down until they're told to do something. That is the biggest pet peeve, I think, that I've ever heard nurses talk about when we've got students or people in that role where they just, well, I get it. Like, okay, I'm just going to sit here and tell me if you need something. Like, you're actually creating a task for me now because I'm responsible for telling you to do things. Like, you should just go do things, right? That you know how to do, that you see they need to be done. Just go do that. And then people will be like, oh my gosh, thank you for doing that. All right. Any tips or suggestions for a nurse residency? I'm in one for a year and I start next week. Woohoo! Love it. I'm a big fan of nurse residency programs. I was in a nurse residency program. So, number one, I have a podcast. Episode 1 of my podcast tells you what to expect. Myself and another experienced nurse talk about what you should realistically expect, what kind of support you should be getting out of it. Residency programs are wonderful, but they're not all created equal. So I actually know hospitals that don't have them, or some that have, like, maybe they're not the best. I also have, and Melissa, I'll get to yours too, and Rashad. I created my own residency program as well. FreshRN.com/courses, where I have a residency program too, because they're not all created equal. If you find you're not getting the support you need, I got you. Please listen to my podcast for tips for a nurse residency program and starting one out. I have a ton in there about that first year and how to get the most out of it, what to expect, which actually I think that rolls into Rashad's question. So I'm going to read Rashad's question and kind of answer both of them. What do you do if you're scared to start your new job as a new grad when you didn't have a practicum in that area? And how much are new grads expected to know? Phenomenal question. All right. Okay. So what do you do if you're scared? I was so scared too. So scared. Rashad, oh my gosh. Like, I don't think I slept like the 4 nights before I started, right? Oh, quick story. When I did my master's, I worked with at a residency program in town, right? So I watched all these residents start, and I'm sitting there and I'm like, I bet they're so nervous. Y'all, they were very nervous. So if you're nervous, that's normal. Nobody is like confident walking in. So here's my quick story. At a hospital, if someone who is not a patient passes out, they call a code. All right. Yes, Rashad's terrified. I was terrified. Absolutely terrified. Like, I think my blood pressure was 190 over 100 that whole week. It's fine. So I go into the room. There's 6 of them, right? 6 new grads getting in this smaller cohort. They're all very nice, eager. I can see through. They're terrified. And so at a hospital, whenever anyone passes out or has a medical need that is not a patient, they call a code because the person's not in the system. We don't know anything about them. That's the quickest way to expedite care. So that day, I hear 2 codes overhead that were not for patients. And I found out later that those were 2 new grads who passed out because they were so nervous. So here's my thing. You're going to be nervous, but intentionally take control of your nervous system, okay? Use those grounding techniques, those breathing techniques. Remind yourself, I'm safe, I'm okay, I'm going to do the best I can. And the other stuff I'm going to tell you is going to help kind of calm your nerves a bit too. But, I think that they just got so tense that they just, how in nursing school, some people pass out, kind of the same thing. So, but I think if you can have some perspective that we can get rid of all that. Okay. Yeah. You're going to have be a little nervous about, okay, I'm meeting new people. This is a new environment, but let's have some realistic expectations for what they do. Cause I think that's what people are so scared. What are they going to expect me to know? I don't want to look like an idiot. I want to fit in. I want to be good at this. Right. And I also did not have a practicum in the area that I started in as well. I did a practicum in a very small emergency department in rural Iowa. And then I got a level 1 trauma center hospital and a cardiac step down unit. Those were very different. So, and I have talked with leaders of new grads at hospitals, and here's what they expect of new grads. And I also have a podcast episode that dives deeper into this. It is called, and it is on my YouTube channel, but you can also go to freshrn.com/podcast. I want to say it's season 5. It's called, What Does a High Performing New Grad Look Like? So this is like summary of that episode. They do not expect you to know all of your meds. They don't expect you to be able to carry a full patient load. They don't expect you to have amazing critical thinking and time management skills. They do not expect you to be this perfect nurse who has to just be shown around the unit. So that's what I thought. Oh, Janelle, listen, wonderful. That's so exciting to me to hear that. So I thought that if I passed the NCLEX, got a good grades in my school, got this job, they should really just have to show me around, show me a few things. No. They know, as leaders of a hospital, new grads all kind of start at the same spot. Even if you went to an amazing school, even if you went to a not so great school, everyone's kind of roughly around the same area. What management, what your people want you to, like the level they expect you to be at. They want you to be accountable. They want you to be coachable, teachable. They want you to be reliable. You better show up on time in the right clothes, be understanding that you're not going to work the best schedule at the beginning because you're going to be with a preceptor, right? You're not going to get to pick your schedule right away. So don't complain about that. That's just part of beginning of a job. But if every time you're corrected, you kind of throw a little temper tantrum, or you throw other people under the bus, or you're like that person I talked about earlier with Janelle about you're sitting and you have to be told what to do, or you don't really care. They hate that. They want someone who is going to want to learn more, want to get better, asking good questions, kind, teachable, will be accountable, will have a desire to learn to do things the right way, not just to check a box or just to get through something, but they want to do it right. So if you can just exemplify those things, and that's not something you're going to show up and just make that impression. You're going to have to put in the time every time you go in and have this demeanor, I am aware that I don't know everything I need to know, but I am willing to learn it. And that is gold. We want that. I would much rather have that nurse than the overly confident, I've got this, don't need to show me, act a little insulted every time you're corrected person. So the first day, first week, have that perspective of, you know what, I am a good team player. I'm going to be a good nurse to work with. I just need some time to figure out how to do it, but I'm going to be good at this. And not think, oh, I've got to answer all the questions right, and know how to talk to the doctor and know how to do all this stuff. I want you to have realistic expectations, like every shift. So I think that if you can have that, it can bring those nerves down a lot. And I think if I keep talking about my podcast, but on there, I do have quite a few that I think that will ease your fears a little bit, and definitely recommend looking at that one. So I hope that helps. All right, let's see. Liz, thank you so much. Wonderful. If possible, do you recommend initially going into something broad like med-surg, like a lot of professors and preceptors recommend? So I love that question because I've gotten that question a lot. And when I became a nurse, it was, you must go into med-surg. You have to do it, right? So one thing I've noticed in nursing is there are a few people who know exactly what they want to do. I want to be a mother-baby nurse. I want to go into labor and delivery, and I want to do that forever. Or I want to go into psych, or I want to be a school nurse. And they just know. I was not one of those people. And I feel like if I had 10 new grads in front of me, maybe one or two, maybe would feel very passionate about one specific area. Abby got med-surg mindset and the residency and woohoo! Yeah, guys, I have a course just for med-surg, y'all. Terrifying. Okay, I will. Okay, Anka, did I say that right? Anka, I will go to yours next. So if you are like, I know I want to be a NICU nurse, like babies, like neonatal, and you get the job, go work in NICU with no shame. Okay. Don't feel like you got to do 2 years in med surg just because, so it's okay. And you get that experience. Like, no, if you're very passionate about something, a specific field, and you know, you want to go into it and you get the job, go into it without shame and say, I'm doing what I love. Right. Like, but I say that as a lot of people don't really know what they want to go into. They don't. I didn't. I thought I did. I didn't. I got into like this cardiac med surg step down unit and I didn't really know what I liked. And it was very helpful for me to just build some basic skills. I ended up going into neurocritical care and I was very thankful that me personally, people can go into ICU and do very well right out of school, but I needed some time on med surg first. And man, I got a really great foundation. And I know people who apply, maybe you want to get into ICU and that's your thing. If you get a job in ICU, like do it. But know that it's much harder to start out in ICU than med surg, but for very different reasons. But I don't think it's this hard and fast rule. I think if you're someone who does not know what you want to do, med surg is a great thing because I quickly learned I don't like young patients. I didn't work peds, but I don't like 20-year-old patients. I don't know how to talk to you. You're 20. I don't know. I like grandmas. I like Mima, who's 85 years old, has a UTI and confused. I gotcha. Like I did not know I would love geriatrics, but I do. And as I came to find out, I really liked neuro. Never would have realized that. But yep. Gotta love Mima, right? So I don't think it's a hard and fast rule. I think depends on where you got the job. Now if I had two options of here's one, hospital A has this really cool maybe burn unit specialty. That sounds awesome, but I don't really have experience with it, but I got that job. And then I also got a job in a med surg unit at a hospital that has a great residency program that's very supportive. I would take the supportive residency program hands down. Okay. Because it is a tough first year. You need all the support that you can get and understanding you can get. And if you have a hospital that has a track record of supporting their new grads versus a cool specialty, that you might be interested in, but you're not sure about, highly recommend whatever is going to have the most structured support for you by far. And you can specialize later. But I don't think it's a hard and fast rule at all. And I think a lot of people have that pressure when they get out of school to start off with their dream job. We have this perspective of like, okay, I went through nursing school and nursing school is really hard. And this is the end of my journey. I'm to the top of the mountain and I end it with my amazing job. That's not it, unfortunately. For a lot of people, they don't get their dream job right out of school. But they are going on a journey to figure out what that's going to be, because a lot of times what a position sounds like, I could say go work in ICU, but an ICU at hospital A and hospital B, those ICUs are two totally different environments because of maybe the management, the culture, the resources, the whatever. I know a lot of people who would much rather work with a patient population they don't quite love as much, but they know that they've got a unit that's supportive and they love their colleagues and it's very enjoyable for them. So, don't beat yourself up if you don't get your dream job. So I do have I'm sorry, I keep talking about my podcast, but I put it all on there. I think it's called I Didn't Get My Dream Job. It's in the last season. I'm going to record more episodes, by the way. But there is one where it's like, here's what you can do if maybe you don't get the job in the hospital. Maybe you don't get the one you were really looking for. Here's some other options. All right. Someone else asked a fresh grad and then ICU, terrified as well. But can you talk a bit about how progress should look like as weeks go by? Absolutely. All right, y'all, 10 minutes. Okay, I'm only going to take up an hour of y'all's time. 10 minutes. You think I can? I'll try to get through these. So, new grad in ICU, challenging but doable. You have to be very intentional with your time. This is, if you're starting in the ICU as a new graduate, here's my advice. Don't have other crazy life things going on at the same time. This is going to be a challenging transition for like 6 to 12 weeks. Well, 12 weeks. Okay. I would not be I wouldn't be buying a new house or moving across the country, or if you can have control over timing of big life events, I would not put them during your new grad ICU orientation. Okay. You're going to take a lot of your mental and physical focus as you physically acclimate to 12-hour shifts, especially if you're going to be on night shift, but also mentally flexing different mental muscles than you have ever had to do before, and speed and whatever that you've never done before. So as a new grad ICU nurse, and this kind of is roughly about the same thing as just a general new grad orientation in acute care. First few shifts is getting the lay of the land. Okay. This is where everything is. This is clean utility, dirty utility. These are all the codes for all the doors. This is how I answer the phone and don't sound ridiculous. This is how I transfer calls. This is how I log into or do this and that. You're really just, it's almost like your assessment with your nursing, with your patient. I'm assessing the scene. I'm understanding this entire new environment I'm going to be in. And with my preceptor, I'm really kind of shadowing them. I'm absorbing things. I'm introducing myself. You are going to be, this is what I want you to do. I don't want you to be the timid new grad who's scared to talk to anybody. You're going to walk up to those those doctors you've never met. Hi, I'm Katie. I'm going to be a nurse on this unit taking care of some of your patients. It's really nice to meet you. That's how you make a good impression with doctors, y'all. Don't be overly confident, but you say hi and go out and shake their hand. I did that. And I heard through the grapevine from some physicians that just really went over very well. I'm confident in myself. I know I'm new. I got a lot to learn. I don't say that, but I'm new. I've got a lot to learn, but I'm excited to just kind of be here. So that's what you're going to do those first few weeks. Then you're going to start with taking one patient. And while you're taking one patient, you are going to have your mind on, how do I appropriately get the meds? Know what meds to take. You're not going to be worried about critically analyzing which med and this and that. I want you to be focused on, this is how I physically know what meds to give and how to get them out of that machine and how to physically administer them with the supplies that I have. Don't get ahead of me now. We got to figure out how to physically do it before we can troubleshoot it, if that makes sense. Because I think a lot of new grads get so focused on the troubleshooting big picture when it's like, hold up, let's learn how to do the IV push at this hospital with these supplies and find out where they are, how you sign in and how you document that you did that. At that time, you're also going to be learning a lot about how to document the assessment. Your provider or your preceptor is going to be making sure you're doing that right. And once you get kind of a little used to that, maybe you have one patient for, it might even be a week, depending upon the unit and what's going on. Then you're going to kind of slowly increase that. And then by the end of orientation, which is hopefully about 12 weeks if you're new in ICU, you should be doing it all by yourself. Something people don't, if you have a preceptor that thinks that this is, hey, we have a patient load that we're going to just take care of together, instead of you taking ownership for those patients as soon as you're able to. Because I have seen people, they're all the way done with orientation almost, and their preceptor is essentially doing half the care for them. Like they're two nurses taking care of one patient load. That's not how it should work. You should be autonomous by the end of orientation. Your preceptor in an ideal setting is sitting at the nurse's station the majority of the shift, checking behind you and making sure you're doing everything correctly. They should not be going in rooms and giving meds for you. They should not be calling doctors for you. You should be doing that all by yourself at the end. And sometimes you have to create a little space for that, because sometimes you have preceptors who are a bit overbearing. And you do have to say, hey, I appreciate all you've taught me. I think I can do this this part myself. You mind if I'll go ahead and call the doctor myself, and I'll let you know how it went, and consistently creating space for that. Because especially in ICU, I've definitely seen a little bit more of the overbearing type of preceptor, because patient safety, and it's hard for them to know when to back off and not. Sometimes we got to create that space. But that's kind of generally how it should go. All right. Oh, Rashad's on cardiac step down. Wonderful. I have a cardiac nurse crash course. You could check that out, which I created that course of all the things that I should have known before I started on a cardiac unit. So there's that at freshrn.com/courses. Pan Lifelore just accepted a neuro ICU. Okay. If you're new in neuro ICU, as a new grad, anyone in neuro ICU, that's a tough field, but that was where I was, and I loved it. So I have multiple podcast episodes. I have 3 on neuro. I also have some blog posts, and then I have my NeuroWise course, which is like all things that you should know as a new neuro ICU nurse. So check that out. I was in a hospital for 2 months, not COVID. I feel like my friends started avoiding me all of a sudden. As a nurse? I'm confused. And Nathan, I need more information before I can provide anything there. Oh, great. Sounds good, Pan. All right. Unit culture is very important, and a bad culture can really make it hard. Yes, they absolutely can. And so it's helpful to notice that kind of stuff. And if you're in a unit that has a great culture, it would be hard for me to want to leave that, because that's not everywhere. So I got offered a job at a MICU, which is a medical intensive care unit, but they do not allow shadowing. And I would really like to get a good idea of the unit culture. Yeah. Oh, and I wonder if they're not allowing shadowing because of the whole COVID thing, maybe. But I do appreciate that, that you want to shadow. I wonder if any other units allow that, or if you know anyone at the hospital and you can kind of get the down low of the unit. Like, hey, what do they? But you could also ask some very specific questions. Okay, I know I can't shadow, and since I can't be there, can I chat? Do like due to COVID? Yeah, that makes sense. Maybe I would ask if I can chat with some nurses on the unit, on Zoom or on the phone, and I would have a list of questions like, what do you think about the unit? What's your term? How long do people stay on that unit? How long has the longest person or people been on that unit? What units do you float? Do you think about those units, and you hear how they talk about other units? Do you like look forward to working with a lot of people there? Or like who's, I don't know, like those kinds of questions where you're trying to understand, do they like their job? Do they enjoy this unit and in a genuine way? And you can tell by the way that they talk about other units that they and the way they answer those questions, if they sound really dismissive and like, yeah, it's fine, I guess. I know, knowing what the turnover rate is at the unit is really big. How often, or do all the new grads stay for a while? Are people there for at least a couple different kind of thing? Would be really good to know. What kind of support does anyone do clinical ladder there? Like, do you guys, how many, are a lot of nurses on that unit certified? That kind of thing. All right, Pan. When should you start looking to complete your CCRN? So, unless the rules have changed, you have to have about 2 years of full-time work in a critical care environment to be able to sit for it. And if you are ready, I would take it as soon as you can. I took mine after about 2.5 years. And that was enough time for me to have enough experience at the bedside. I have a CCRN study guide. If you go on my website and just search CCRN, I have a couple posts about it. And I have a review I really like. The review I did back in 2015. I would not recommend that one. It's kind of out. Well, they have a newer one since, but I wasn't super impressed with it. But I found a different one that I really like. But most specialties, you have to work in the specialty for 2 years full time to take your board certification. But I highly recommend doing that. I really think that it's very great. It's great for your professional development. You learn some stuff that you're like, oh man, I've been doing that wrong. Didn't know that was a thing. Like, oh wait, that's why we do that. Like, it was because you get out of like your information overload place where you're like, oh, okay, I've gotten to be competent and understand why I'm doing this, and I'm getting better at doing this. Now let me learn why. Now let me learn more about the mechanics and what's behind and the rationale for these things. And that really helps deepen your practice. And I have a feeling if you've been there for a couple of years, you're going to get asked to precept. You're going to get asked to be a charge nurse. So having that information there is great. And a lot of hospitals will offer to pay for the certification because it looks great for the hospital when they have a bunch of certified nurses. So I'd be negotiating to get that bad boy paid for. I'd be negotiating to get the review paid for if they don't already offer that. I would, because then you'll have more credentials. It'll look great for the unit. It's advantageous for them to have a certified nurse on their unit. So do that, y'all. Let's see. Yes, if you can get answers about climate to the manager too. Yes, so you could ask the manager. I would do both. So see what the manager says and see what the people on the unit say and see if those two things align, right? You can really get an idea of what a culture is like if you talk to those two people, because a manager, you want to hear how they're going to answer questions and how much they really know about the people that work for them and how much they really care, and see if what they're saying really aligns or if they're very disjointed and disconnected. I would ask the peers, or if I was able to chat with peers. So what's everybody think of the manager? Like, is this how long have they been in that role? How do you feel about their leadership style and skill? I don't know about I'd say skill. I would say style. Does it really connect with a lot of people, that kind of thing, so that you can get a better understanding? Because that kind of stuff you can observe when you're there. If people there are constantly complaining and talking bad about each other, I wouldn't want to work there. All right. I listened to your interview podcast and asked those questions like you suggested pertaining to unit morale, especially their ideal nurse. Yes, wonderful, Abby. I'm so glad to hear that. Yeah, I interview in the podcast, y'all, just if you haven't listened to it. At the first season is the woman who precepted me, 7 or 8 years ago, Elizabeth. She's highly experienced code team nurse. Oh my gosh. So then I pulled on another person, Melissa. She's been a nurse for over 20 years, highly experienced neuro ICU nurse. And then I had the opportunity to interview a bunch of people at the NTI conference for the American Association of Critical Care Nurses. So there's some interviews there. But then I got to interview 2 nurses. One is a director of a residency program, and one was a manager of that program. And their insights on hiring and onboarding new grads were amazing. And actually, I do have an interviews course that I do with Amber, who is one of the people I interview. And they just have such good insights. And I think it's really helpful as a new grad to hear what they really think, because it very much did not align with what I thought they would think as when I think back to me as a new grad. All right, last question, y'all, because it's been over an hour and we'll do one more. I'm hoping to start as a new grad in neuro med-surg. Would you recommend using med-surg mindset or neuro-wise? Oh, that's a good question. I say neuro-wise. I have a 1 module on stroke in neuro or in med-surg, but I recommend neuro-wise. And while both would be great, because in one of the things I do talk a little bit about time management and neuro-wise, but in med-surg, I have 2, I'm really excited about these because this is what I really needed to learn when I was a new med-surg nurse. I freaked out a lot about report because it was very intimidating to me, both receiving report and giving report. So I have a big section about this is how you're going to be amazing at report. Then I have a section on this is how a shift should flow. Nursing school really teaches you, these are ABCs, who's dying, right? How do I get to those people, right? And how do I do that? But the reality is that's not every shift. And that's not most shifts, honestly. I mean, I can probably count on a couple hands the times that I went in and things were actively going bad as I walked in and I had to use the ABCs. The rest of the time, things were fine. But I had a million things I had to do and I didn't know how to order my time. So I have a whole anatomy of a shift section, which is new. That is not in the NeuroWise course. NeuroWise dives deep into all things neuro. Now, here's the thing I would do though, is you could always see if your hospital reimburses for educational material, because we provide contact hours, and some hospitals will, if you're doing, they'll reimburse for your contact hours. So I would consider that, because I think that there are pieces of both that would work well, but you're not going to find that neuroeducation anywhere else. I do go into neuro ICU stuff, and if you decide to go to neuro ICU, it will also be a great foundation. But I think I would do. I think I would do that. All right. All right, guys. Well, it's been an hour. I will sign off for now. I'm going to, I think, do these once a month. I'm thinking if people end up enjoying these. And so bring your questions and I will chat with you guys then. Please check out, if you enjoyed this, head over to my website, freshrn.com, sign up for my email list. Every week I send a little clinical pearl, a little tidbit, piece of advice, story from the bedside. I also highly recommend a lot of this advice and question answers. I do go through a lot of that in my podcast, and I'm going to start recording new episodes of that very, very soon, and hopefully get back to releasing them weekly. So thanks, guys. Have a wonderful afternoon.